Alrighty, well, hello everyone, Professor Kyle here. Today we're going to do a relatively quick run through of the appendicular skeleton in preparation for practicum number 2. Now, I'm recording this on something of a time crunch myself. It is also the weekend, and so I know you guys are probably studying, so I want to get this out to you as soon as I can. So we're going to try and do this in one take, or as few takes as possible, assuming no interruptions occur. With that being said, let's go ahead and launch on into it. So obviously, previously we've discussed axial skeleton, right, which is your rib cage, your spinal column, your cranium, and that sort of a thing. Now we're talking appendicular, we're talking appendages, we're talking your arms and your legs and everything that comes along with it. To get things started, some important kind of study framework we should mention. So first of all, learn the bones themselves, right? You got to start somewhere. So let's focus on learning the bones, being able to identify them. And then from there, we're going to be learning about the features of the bones. And using those features, you will be able to then figure out how to distinguish left from right. So that's a very important framework. And always try to relate things back to your own body, right? You have one of these things that we're studying. So you kind of have a built-in cheat sheet in that regard. So when we start talking about, the radius and the ulna and the arm and stuff, kind of palpate those features on your own body. I have a timer that just ended. Palpate those features on your own body, and that will maybe be useful for you when you sit down to take the test as a reminder. That being said, let's go ahead and start with the upper arm. All right, so here we have the pectoral girdle. Now, another quick aside before we launch in. I'm used to giving this lecture in class where I get to use lots of complicated gestures and I have a full skeleton model as well as individual bones laid out in front of me. I'm currently sitting in my computer space in front of a chair with a microphone. So with a very limited framing on my, here's the edge of my green screen. So I'm going to want a gesture and I'm not going to be able to do that. So you may see me do stupid gestures or excessively use the doodling feature or the pen illustration tool on this. So just bear with me. This is my first time giving this lecture in this format. I'll do the best that I can. Anyways, that's enough context. Let's launch on in. So to start things off, we have the pectoral girdle. Okay, it's your shoulder for all intensive purposes. It is composed simply of two different bones. Speaking of using the laser pointer, we have the clavicle, which you can palpate right here across the top of your chest. And then we have the scapula, or your shoulder blade, as you may commonly refer to it as. Another fun fact about the whole upper appendage is the only attachment point, bone to bone, between your arm and the entirety of your arm and your axial skeleton is right here between the clavicle and where it attaches onto the sternum. Okay, everything else is just supported by ligaments and tendons, by soft connective tissue. Focusing in on the clavicle, we just have a couple features that we're going to note. Again, in more advanced anatomy and physiology courses, you will break things down further, but we just want to kind of hit some of the high points. And again, these features are going to be the ways you're able to distinguish left from right. So bear that in mind as we review. Starting things off, we have the acromial end. Okay, so this is going to be the lateral edge. This is the outside edge of the clavicle. It would be this edge of it if you were to feel it on your own body. Is called the acromial end because, as we'll see in a moment with the scapula, there is a process on the scapula called the acromion. So the part of the clavicle that attaches to the acromion is called the acromial extremity. Okay. Another feature, we have the conoid tubercle. Okay. This is going to be, if it is correctly placed, if you're trying to correctly anatomically place this, it's going to be kind of on the superior side and the posterior side. It's kind of on the back edge of the clavicle. And then shifting to the medial end, we have the sternal extremity here. This is a relatively flat surface in terms of the end point. I often gesture in class. It's the part you would slam down on a table if you wanted to kind of use this bone as a hammer, which would be a terrible idea. But if you were to try to hit it with a flat surface, you would use the sternal extremity because it's more of a blunt end. Okay. So we have the acromial end, lateral side. We have the sternal extremity on the medial side. That's attaching to the sternum, right? Same sort of naming conventions we've seen before with, we have the temporal bone with the zygomatic process because that's attaching to the zygomatic bone. Same sort of thing here with acromial and sternal. Those are big hints. And we already mentioned conoid tubercle. So we'll keep it relatively simple there. And then if this was to show up on an exam and you had a clavicle, and perhaps a question would be identifying, is this a left or a right, or identifying the conoid tubercle, that sort of thing. The way to orient it, my recommendation is always place it down on the table with the smooth surface up. Okay, smooth surface up. Notice that here we're looking on the kind of inferior posterior portion of the bone, and it's got some processes and some tubercles back here and some ridge lines, so it's a much more rough surface if you feel the bone. Whereas here on the superior surface, more superior and anterior, it is a much smoother surface. So orient it that way, and then take that smooth flat bit that's almost a spoon sort of a shape, and that would be the lateral edge, and the more blunt end is going to be the medial edge. Okay, medial extremity. Moving on to the scapula. Okay, so bit more stuff going on with the scapula. It's a fairly complex bone. So we have the aforementioned acromion right here. Okay, at the lateral end, it is this big guy right here, or looking on the posterior side is this big process right here. So again, that is what the clavicle attaches to right here. Okay, basically kind of sits. Sorry, my camera's lagging. Sits on top to / next to it. Okay. Next, we have the coracoid process. So if you're just looking at this bone by itself laying flat on the table, you might be inclined to think that the clavicle attachment would be on the coracoid process, because when this bone lays flat on the surface, kind of the most upward facing portion is going to be the coracoid process, but don't get that messed up. The coracoid process is actually a little bit lower down here on the side, okay, whereas your clavicles inserting, see, I'm already trying to use my own body as a model here, is higher up over here, okay? So it sits more forward. It's much more closer to your pec muscle than to your deltoid, would be another way to frame it. And it's involved as an attachment point for some muscles, which we will discuss in the next lecture when we cover muscles. Next, we have the glenoid cavity. Okay, this is the socket to the kind of ball and socket joint of your shoulder. Okay, it is this surface right here. This is where the head of the humerus, which is your upper arm, this big guy right here, it is where the head of the humerus inserts into the scapula, and then there's a bunch of ligaments holding that together. Another key point is that joint needs to point laterally. Okay, so if you've ever built a model, or if you have, or if you will build a model, the glenoid cavity needs to be facing outward, because your shoulder is out here. Sometimes you have a natural inclination to kind of want to set these as wings with, like, so they can almost like flap in a sort of way. That would be placing the bone backwards. Okay, so we want the glenoid cavity facing outwards, because that's where it interfaces with the humerus. Next, we have the spine. The spine is this ridge line here on the posterior portion. You can usually palpate this. Pretty much everyone can, unless you're like super jacked. It's this very hard, bony ridge line that basically runs along the back of the scapula. Again, insertion point for muscles. And we'll see some muscles are actually named based off whether they are on the superior or inferior surface of the spine, or whether they attach to the spine, for example. We have the inferior and superior angle. No need to overthink this. Okay, we have inferior right here. Do remember, okay, lateral side is going to have the lateral angle, and then we have superior angle is on the top surface. Okay, just keep those very intuitive. Don't overthink it. Suprascapular notch. Okay, right here, this little guy. Very simple on the superior border. Infraspinous fossa. Okay, infraspinous fossa. We have this little region right here. So we have the spine, and then we're saying infra, or kind of below fossa. Okay, so that's going to be this area right here. Then we have the supraspinal fossa, right? Supraspinous fossa up here. So this large plate, kind of a attachment point for muscles, relatively smooth surface, and divot right here, and then supraspinal fossa right here. And then lastly, we have the subscapular fossa. So to keep these two clarified in your mind, on the anterior surface, in other words, the part where your rib cage attaches. Okay, so like, trying to figure out this camera thing. This side surface, which is between the scapula and between your rib cage, that's going to be the subscapular fossa, that surface. Okay, whereas the infra and supra spinal process is the actual like posterior or dorsal side of the bone. Okay, so keep that clarified. Moving on to the arm. Okay, so we have 3 portions of the arm that we will break down. Now, an important kind of semantical distinction that we should make in day-to-day conversation in colloquial terms, we refer to the entire appendage, your upper appendage, as your arm. Technically, by anatomical or scientific definition, it is just your humerus that is your arm, and then the remainder is your forearm and then your hand, right? So we kind of delineate those. So the humerus is technically the arm. Just a quick side note there. Speaking of the humerus, there are more features that we could go into, but again, this is an introductory level course, so we're just going to cover kind of the main important ones, particularly in reference to distinguishing left from right. So we have anterior and posterior view, and we'll note a way to really quickly distinguish whether it's facing forwards or backwards, anterior or posterior, in a little bit. But we'll start going top to bottom. So first we have the head. Technically, there's also a neck to this bone, and technically these are features as well, but we're not going to worry about that. So we just have the head. This is the point that attaches to the glenoid cavity that I mentioned before, okay? This surface right here, okay? So that's the socket, and then this is the bone that attaches into it. Then we have a neck, which is this region right here, just along the edge. It's not labeled, but just note that, okay? Typically, the head is of joints are covered in a form of hyaline cartilage. So basically, where the hyaline cartilage ends is where the neck of the bone begins. We have the deltoid tuberosity. On some bones, it's more noticeable than others. In all cases, it'll be a slight kind of elevation and also a much more rough surface relative to the rest of the humerus bone. The reason for this kind of rough surface is, again, attachment of muscle, specifically of your deltoid, as we'll discuss later. So your big boulder shoulder, when this comes down and inserts on that lateral edge, that outside edge of your humerus, it is inserting on this deltoid tuberosity. So in this case, yeah, we just said it. I was about to reiterate myself again, but we're trying to do this quickly. All right, moving down, we have the medial and lateral epicondyles. Okay. Medial epicondyle, you can palpate this on your own arm. On the inside edge of your arm, there's kind of a bumpy ridge at your elbow. That is the medial epicondyle, okay? The reason we have these, insertion for bones in your forearm, as well as portions of like your brachialis and stuff. But is an attachment point for your muscles, okay? Then we have the lateral condyle, which you can also palpate on the outside edge, a little bony protuberance over there. So medial is going to be facing inward, right? So that makes sense, kind of the more, and it's usually the more pointy one of the two if you're trying to figure out orientation. And the medial is also going to be oriented in the same direction as the head. They are both pointed inwards, okay? Now, how do we distinguish, though, anterior or posterior, right? Because if we know what left and right is in relation to that, well, I can make an argument if I'm just holding a bone in front of you. Again, I don't have a bone, so I can't do this. That you could know which side needs to face medially, but you won't know whether it's a left or a right, whether it's the bone is in its entirety is facing the right direction. The way to do that is to look for this divot right here. It is not labeled. I forgot to label it. My apologies. But is called the olecranon fossa. Okay, so it faces posterior. This is the posterior view right here. And it's a fairly significant divot with two joint surfaces, the trochlea and the capitulum, inferior to it. And this divot in the bone is basically accommodating a hook joint that we will see make sense in just a moment when we talk about the first bone of the forearm called the ulna. So again, make sure that large divot, that olecranon fossa, is facing posteriorly. And if you have that facing that way, and then you look at where the medial epicondyle and the head of the bone are facing, you will know where the medial surface is, and therefore whether you're looking at a left or a right humerus. And then again, I kind of brushed over it because I got excited about noting left from right. But we have the trochlea and the capitulum. So the trochlea is below the medial epicondyle, and the capitulum is more lateral. Okay, those are surfaces for basically your elbow joint. Again, let's bear in mind that olecranon fossa on the posterior portion, this little divot in the bone. What is that for? Well, it is for this guy right here called the olecranon process. Olecranon process are pointy bits, fossa are divots or holes. And so this is what is ratcheting into that. And so if you were to think about your elbow, feel that pointy bit, that is the olecranon fossa that you're feeling. And notice as you kind of bend your arm, it kind of disappears up into the bone of your humerus. And so basically to accommodate this notch or this process is why we have that fossa in the ulna. In the humerus. I get these names mixed up. All right, forms the medial portion of the forearm. So if you're holding your arm in front of you, it's going to be towards the middle surface, right? Okay. This guy right here on the pinky side is another way to remember it. In terms of landmarks, we have the olecranon process, which we already noted before. This is the majority of the stability for your elbow. We have the trochlear notch. Okay, trochlear notch is just that interior surface of the hook. So this is the hook. So this would be the olecranon fossa. This interior surface of that joint is going to be the trochlear notch. And then we have a slight kind of front lip to this joint as well, and that's called the coronoid process of the ulna. We'll see coronoid process in other instances, but yeah, this is the coronoid process of the ulna. And then outside of that, we have the radial notch. Okay, so if you're holding an ulna and you're trying to determine whether it is the left or the right, left or right ulna, 2 points that I would say are very helpful. So obviously, whichever side has the hook, okay, that back side, that's going to be the posterior surface of this bone because it needs to interface with the humerus. And then for left and right, so that'll tell you which way is backwards. For left and right, 2 things. We have the styloid process listed down here at the end, okay? Distal end is this little pointy bit. This is a part of your wrist. All right, I had to take a brief pause. I'm not sure exactly where I left off, but I believe I left off with distinguishing left from right with the ulna, and we were talking about the radial notch and styloid process. So starting off with the one I tend to rely on more in terms of it's just immediately evident and is helpful for placing left and right. We have the styloid process, okay? The styloid process right here. It's this little pointy bit at the wrist end of this bone. Okay, this is elbow up here, wrist end down here. Pointy bit is going to be pointed medially in anatomical position. Again, that's hard for me to do because I'm sitting down. But imagine my hand was down by my side. It would be the medial edge. It's the pinky side would be another way to think about it. It's the pinky side of your wrist, okay? Secondly, in terms of distinguishing direction, we have the radial notch. The radial notch is up here. It's relatively hard for me to illustrate what this looks like in this particular perspective. But basically, there's a cutout in the side of this bone that accommodates the head of the radius, which is the next slide right here, okay? So literally like this surface right here kind of, we're going to try using the pen. Why is my cursor not letting me get off the page? There we go. Try using the pen. But so obviously there's this bit of a protuberance around the head. So the notch is kind of shaped like this, okay? If that makes sense, but it's running lengthwise of the bone. Hopefully that makes sense. But it's basically a good little corner for the bone to nestle into. Okay, so that's going to be the radial notch. So if you take the radial notch on the lateral side, okay, and then the styloid process facing the medial side, the pinky side, that's how you'll be able to figure out whether it's a left or a right ulna. Speaking of the radius, we'll go ahead and move on with this one. So we already have the aforementioned. I need to switch to the laser pointer. Keep forgetting. We have the head of the radius, which we just spoke about. So this is going to be up at your elbow. And then we have the neck, okay, this kind of region right here, okay, where an epiphyseal growth plate would have been during your adolescent, your childhood development, which eventually fuses and closes by the time you reach adulthood. Then we have a radial tuberosity. It's this kind of ridge line. It crosses sort of the anterior surface of the bone. It's a little bit more evident on some bones more than others. Just remember, if you feel that rough ridge line, that's going to be the radial tuberosity. And then we have the styloid process down here. So this is the opposite end, or the opposite side, rather, at your wrist. So we have the styloid process of the ulna, okay, on the pinky side. And then we have the styloid process of the radius on the lateral side, or on basically your thumb side. It's over here, okay? And that will be how you distinguish left and right. So put the head towards the upper superior surface in anatomical position if your arm was down by your side. Styloid process on the lateral outside edge, okay? And that will be your radius. The other thing about the radius is if you, oh my gosh, I'm not trying to punch the camera. But if you take your wrist and I always do this example in class where it makes more sense. If you rotate your wrist or you pronate your wrist inwards, okay, the bone that's doing the majority of the rotation is your radius. And then the one that's staying relatively in the same spot is the ulna, okay? So like the ulna is kind of staying in the same spot, but this bone out here is totally crossing over to that side. So the radius rotates. All right. Here we can just see everything put nicely together. So elbow up here, wrist down here, styloid process of the radius on the lateral edge. Then we have the styloid process of the ulna on the medial edge. That here's where we can see that radial notch of the ulna interfacing nicely with the head of the radius, just to kind of bring everything together. Here's the posterior view of the same relationship. Okay, we have the olecranon process right here. And then here's the back end of those pointy bits that we were discussing at length. Cool. Oh, hand bones. Hand bones. There's a lot of hand bones. Luckily, the 5 metacarpals and the 14 phalanges are relatively straightforward. We have some simple naming conventions that make those very easy to remember and to categorize. The carpals are annoying. I'm going to be honest. From a memorizational perspective, they are complicated. But luckily, they're in 2 rows, and it is not the end of the world when it comes to memorization. And we have a little mnemonic that I'll give in just a moment to kind of help remember these things. So when it comes to the carpals, think of these as your wrist bones, okay? And then this would be the palm of your hand, and then these are your digits up here. We have the proximal row, okay, the row that is closer to the midline, so it is the first row, or it is the part towards the lower portion of your wrist, closer to your forearm. We have 4 bones. We have scaphoid, lunate, triquetral, weird word, and pisiform, okay? Distal row, so that was these 4 right here, okay? Then on the distal row, we have the trapezium, which makes me think of like a trampoline, club sort of a thing. We have the trapezoid, which is just straight up a shape. Okay, then we have capitate, which capital or capitus means head in Latin. Then we have hamate. I forget what hamate means in Latin, but it's irrelevant regardless. All right, so it's a lot of rote memorization. The mnemonic that I can give you is, do I dare try to write this out? I'll just write like the first letters. So Sally, okay, left. This I swear this is harder than it looks. Left the party to take, oh Lord, it's an A. Take Christina, Carol, or Carrie, or whatever name floats your boat. Just a name that starts with C. Christina goes here. Take Christina home. Okay, I feel like I'm getting better at this as I write. That is simple mnemonic, each of the letters representing the first letter of the name of the bone. If that's useful to you, great. If you come up with your own mnemonic, awesome. Whatever helps you remember these bones. We're not going to get into any sort of physio stuff with these. To be honest, it's not my forte. So just in terms of true rote memorization, this is probably the heaviest burden on this stuff. So Sally left the party to take Christina home. Scaphoid, lunate, triquetral, pisiform, then trapezoid or trapezium. See, even I messed up. Trapezium, trapezoid, capitated, hamate. Now moving on, this will be much easier by comparison. The metacarpals and phalanges. Fun fact: I've spiral fractured. I probably mentioned this in lecture. Spiral fractured my ring finger metacarpal, but there's a better way to name it than ring finger metacarpal of my left hand. The metacarpals are these guys right here. So we have one, and then I'll outline them. It's easy enough to do. You couldn't even see my gestures because we're doing the wrong things. Okay, so these are metacarpals. And then all of these guys are the phalanges. Okay. In terms of naming convention, it's very simple and straightforward. If you ever taken piano lesson, you know how to number your fingers 1 through 5. So we start with 1 on the thumb, and then 5 is your pinky. That's how we name the digits of both our hands and our feet. In feet, it would be starting with your big toe and ending with your pinky toe. And then we name, so then we would have basically second metacarpal, okay? That would be this bone right here. Okay, we gotta clear the drawings because it's getting a little chaotic. And then we have our phalanges, okay? And with our phalanges, we have just proximal, middle, and distal phalanges, or intermediate phalanges is occasionally used. Proximal, medial, and distal phalanges. So this bone of your ring finger, okay, we would call that the basically proximal phalange of the fourth digit, or fourth proximal phalange, okay? Nothing too crazy, nothing much more to be said. Moving on, here's just a quick summary, everything put into context on the anterior view. Okay, so this would be the palm of your hand that you're looking at, okay? And then here we have the top side, the posterior portion of the hand. Same information. All right, jumping all the way down to our lower extremities. Okay, let's talk about the pelvic girdle. Pelvic girdle attaches to the axial skeleton, to your spinal column, okay? And we're going to start things off with our hips, or our coxal bones is technically the name for them, but think of it colloquially as your hips. It's technically composed of 3 separate bones that fuse together fairly early on in your childhood. Those 3 bones, though, are still how we end up naming the different regions of the consolidated coxal bone, and those are the ilium, the ischium, and the pubis, okay? So we'll see on the next slide. I'll go ahead and jump to that just briefly. So the ilium forms typically of what you think of as your hip, okay, right? That big crest on the side of your body. The ischium, if you were sitting down right now, which you probably are watching this lecture, would be maybe you like watching lectures standing up. I don't know. If you're sitting down right now, the majority of the pressure is on the ischium right here, and then this would be the pubis region. This is more anterior, kind of where the reproductive organs, the pubic region, is. Anyways, running back over here. Okay, some other features that we need to know. We have the obturator foramen. Okay, it is the one big large foramen on the side of the bone, right there, passageway for a lot of nerves and blood vessels. And then we have the acetabulum. Okay, the acetabulum, this is the socket for your hip joint. Okay, this is where your femur is interfacing with your pelvis. Okay, these guys right here. We'll see it on this view as well. So here we're looking from the outside edge. Okay, this is a lateral view of the hip bone. In other words, the femur, my beautiful art, the femur would be right here, okay? Interfacing at the acetabulum of the coxal bone, okay? So focusing in, though, on the ilium, I'm going to erase my little drawing. We have a couple landmarks that we need to know. They're all fairly intuitive for the most part. So we have the ilium, which is this upper region. Again, once it was its own bone, and then these entirely fused together. We have the iliac crest. This is that ridge line that you can feel along the side of your body. This guy right here. Okay. We have the anterior gluteal angle. Okay. Or gluteal line. Sorry, gluteal angle. I skipped and I was thinking ahead to another point. Anterior gluteal line. It's sometimes not particularly clear if you're looking at a physical model, but just imagine that it's this ridge line kind of running along the anterior surface of the bone. Then we have the greater sciatic notch. This one's a little bit more interesting in terms of physiological application. You may have heard of a condition called sciatica. Okay, this is essentially nerve pain that usually originates around the pelvic region, but can also be disseminated broadly throughout the lower body, even sometimes presenting in other weird spots. It is because there is the sciatic nerve that runs around this notch right here. And if there is some sort of physiological complication of bad posture, other pathologies, or just broadly speaking, inflammation of this region that is applying pressure to that nerve, to the sciatic nerve, that will cause kind of a disseminated pain throughout the body. So that is where sciatica typically comes from. We have the greater sciatic notch we talked about, and then inferior gluteal line. This is basically rounding the edge. There's something of a tissue difference between the bone forming right around the acetabulum and then basically the majority of the ilium. And it is this little line right here. So basically kind of almost the neck, if you will, of the acetabulum. That's not what it's called. It's just the inferior gluteal line, but it's right there. All right. Here we're just getting another perspective. Did I skip 2 slides? Or no, I did. I did. Okay, this is the next slide. Ischium. Okay, the ischium, as I just mentioned, is where the majority of the pressure when you are sitting is on. This is the most inferior portion of your hip. Couple things we need to note. Again, just another angle on the obturator foramen. Cool. Acetabulum noted. And then the pelvic brim. This is easier to see in this picture. We just kind of randomly put it on this slide. But basically, the 2 halves of your coxal bone, when they form together, form what is called the pelvic rim. A significant part of the pelvic rim is the pubic crest. Okay, so we have the pubis region, which is this anterior surface. Okay, so this would be the back of the person. This would be the front of the anterior surface of the person. And we just have 2 features that we're going to note. We have the pubic crest, which is kind of this top edge ridgeline right here. Okay, so this is a large portion of what we just described here with the pelvic brim. And then we have the pubic symphysis. Okay, this is a form of connective tissue that is very significant for certain physiological processes, particularly for females during childbirth. It is stretchy and can flex out a little bit. Very helpful for accommodating the passage of a baby. That's about it that we need to discuss there for now. Here's just a nice little summarized view of everything that we talked about. So the ilium is the crest, with the iliac crest as the ridge line. That is the majority of what you think of as your hip. We have the acetabulum, which is partially composed of all 3 bones, forming the coxal bone, greater sciatic notch, sciatic nerve, sciatica as a physiological condition or clinical presentation. Inferior gluteal line, kind of lining the outer edge of the acetabulum, anterior gluteal line, just kind of this little divot running along the surface of the ilium. We have the ischium, which is what you are probably sitting on right now. The obturator foramen, very important for passage of nerves and blood vessels. Pubic region on the anterior surface. And then the pubic symphysis being the binding point connective tissue between the 2 frontal portions of the coxal bone. Same thing, different perspective. Cool. This is the articular surface upon which is the pubic symphysis. Okay. More examples. Trying to keep this relatively quick. We're already at 40 minutes on this particular recording, so this is going to be like an over an hour long lecture. All right. Some not anecdotal, scientific, but just side notes about physiology and physiological differences between male and females. One of the easiest ways to distinguish male from female, specifically like in archaeological applications, like we dig up a skeleton out of the ground and we're like, oh, this is, probably a mid-20s female. You're like, how did you do that? When all of the soft tissue has already decomposed. Well, one of the easiest ways to do that is actually using the pelvic girdle as basically a diagnostic tool, suppose would be the term. Looking specifically at the pubic arch, okay, this angle right here. So again, as we mentioned before, the pubic symphysis being flexible and the pubic arch being at a more obtuse angle, well, this would be very useful. Having an obtuse angle here would be very useful for passing a child. So typically we see a much more obtuse or a much larger angle in this area on females than we do on males. Whereas with males, we have a much steeper pelvic girdle, okay, and a much steeper pubic arch, or a much narrower angle in the pubic arch, I should say, on males. Some ways that this presents differently than in terms of kind of kinesiology. So females obviously are much more adapted to carrying a child on their abdominal cavity and to passing the child during childbirth. Males, on the other hand, due to this steeper angle, this essentially creates a better leveraging angle for handling external loads. So internal load is pretty decent with carrying a child for female reproductive purposes. For male anatomy, accommodating high levels of external load, think of like a deadlift or a squat, something along those lines. This angle of engagement, and then obviously there's other things that affect the physiology of like a sort of powerlifting movement, such as the length of the femur and that sort of stuff. But this generally is better for supporting that sort of force. So then we see the differences there. Okay. Speaking of femurs, lower limb. So the femur is roughly equivalent to the humerus from the upper limb. Okay, so we kind of even notice some similarities here. We have the head, then we have these instead of we have these condyles, right? We have the medial epicondyles, which is kind of the hard bone lateral surfaces, and then covered in hyaline cartilage, we have the condyles right here for your knee joint. So in terms of landmarks, we'll go top to bottom again. Okay, so we have the head, which we've noted before, typically covered in hyaline cartilage, and then there's a little divot at the end of it. Okay, there's a little kind of, it's almost like someone took a chisel and like chipped out a little part of the head of the bone, and that is called the fovea capitis. Capitis means our English translation is capital, means head in Latin, right? Like kind of the top or the most important. So it makes sense, being that this is the head of the bone, that we would call this the capitis fovea. Fovea mean divot. So basically, kind of like hole or trench on the head is basically what fovea capitis would roughly translate to. Then, of course, we have a neck. This time it's a little bit more, or noticeably more significant than compared to the neck on the humerus that we've discussed previously. And then we have two features. We are going to note these here. We have the greater trochanter and lesser trochanter. So this is a word we've not encountered before. We've seen condyle, we've seen process, we've seen coracoid, those sorts of things. Trochanter is new to us. In terms of keeping these straight, well, the larger one and the one that is higher up is going to be the greater trochanter, and the one that is lower and smaller is going to be the lesser trochanter. Keep it as simple as that. Moving down to the inferior end of the bone, we have medial and lateral epicondyles, just like we saw previously. Although we should note that the joint portion of the knee, we should note as being just condyles. Okay, so epicondyle is kind of the larger process, if you will. Condyle is the actual joint portion of it. And as before, the medial condyle or the medial epicondyle is oriented in the same direction as the head of the bone. And then for the purposes of distinguishing posterior and anterior and posterior for this bone, just like we use the olecranon fossa on the humerus as like a way to figure out front and back. So the easiest way to distinguish front and back here is going to be that patellar surface. So the smooth bit that runs basically in line with the top or the orientation of the femur, that's going to be the anterior surface, because this is where your patella, where your kneecap is tracking, okay? Tracks along this line. You can also think of the U shape. So if I was to look at the condyles, I'm going to do another terrible drawing. If we look at the condyles on the posterior portion of the femur, they would look something like this. Okay. So this being the back part, this would be the posterior. Hopefully that is within front. It's behind my camera. I am silly. All right, let me draw it again over here. I'm not gonna do another take. We're doing this as fast as we can. Okay, so these would be the two condyles right here. And this would be the back part. This would be the posterior portion. Okay, does that make sense? I'm so silly. I drew it behind myself. Alrighty. Anything else? No, that's basically it. Here's a nice summarized view. Patella, kneecap. Not going to spend too much time with these things. The patella is kind of an annoying little bone to orient. The best advice I can give with this is that the apex, okay, the more pointy bit is pointed downwards. All right, just remember that. Pointy bit is pointed downwards. Apex is pointed downwards. And then the facet of the lateral side, okay, the outside edge, this tends to be a little bit more of a steep angle. If I was to draw like what this surface looks like, it would be kind of something like this. Okay, so this surface would be here. Okay, it's a little bit more of a steep angle on the patellar bone. Best advice I can give. All right, lower limb. We're almost done. The lower limb is composed of two bones, just like we saw with your forearm, okay? Instead of ulna and radius, we have the tibia and fibula. Although obviously our legs are not worried about pronation and supination nearly as much as our upper arms are. They're much more about taking force and propelling us forward. So the larger of the two bones, the tibia is tough and the fibula is fragile. That is a quick little mnemonic to keep those two clear in your head as to which is which. Tibia is the big guy that we can see here, and this is the fibula. Fibula is going to be on the lateral edge, the outside edge of your leg. You can feel where the head of the fibula interfaces with the head of the tibia, the superior surface of the tibia, on the outside edge of your knee. There's a little like bump on the side of it, and that's going to be the head of the fibula right there. Outside of that, some major landmarks that we need to know. So we've seen it before. We have medial and lateral condyles, not epicondyles. Okay, we're just talking condyles here. Medial and lateral condyles. This is the anterior surface, this is the front of it. So this would be your shin right here. We have the anterior border, which is that hard ridge line right on the edge of your shin. This guy running here, running basically the full length. We'll see how that relates to delineating some muscles next week. And then we have, let's see, anterior border we talked about, and the medial malleus. Okay, so we had the styloid processes of the fibula and ulna in the forearm. Here we have the medial malleus, okay, this very large chunky bit right here. That's going to be on the inside edge of the tibia. And then juxtaposing that on the fibula, we have the lateral malleus, which is going to be on the outside edge, okay? Is this fairly long, more like spear-shaped protuberance for the fibula. Again, in terms of distinguishing kind of top and bottom, sometimes the fibula can be a little bit of a sticking point. What I would say is the head is shaped kind of like this, right? And then we have the shaft of the bone here. But it's overall, it's more flat, okay? Down here with the inferior surface of the fibula, the lateral malleus, this is much more like this sort of a shape, okay? And that is because this is where your ankle is, okay? So we want to provide stability on both sides of the ankle. So that's why we have such a significant medial malleus and lateral malleus. So the more spear-shaped end is going to be the inferior portion, and then the more flat portion is going to be the head, all right? Terrible drawings, I know, but hopefully that helps clear that up a little bit. Anything else we need to note here? Nope, that's about it. Here's all of it put together. So again, your ankle would be down here. Your talus bone, as we'll see in just a moment. All right, lower limb, talking about the foot. There are 7 tarsals rather than the 8 that we saw with the hand. But then we still have 5 metatarsals and 14 phalanges like we've seen before. Luckily, the the tarsal bones are relatively easier to remember than the carpals in the hand. And that is because we basically just have a handful of uniquely named bones here. And then we have the cuneiforms, which takes up 3 of them. Okay, so these 3 guys right here are just the medial, intermediate, and lateral cuneiforms, which is kind of a funny word because that's the name for form of script language, but I digress. In terms of keeping these clear, they're all very uniquely shaped too, so that helps us a little bit. The talus, this is forming the majority of your ankle. Okay, this big guy right here. I should outline more often. I feel like that's somewhat useful for me to do. And then we have the calcaneus. The calcaneus guy, this one right here, is this big guy. This is your heel. Okay, when you think of driving your heel into the ground, you're thinking of the calcaneus muscle. We'll see it very evidently on the next picture. When it comes to metatarsals and phalanges, same naming conventions we used with the hand apply here. So we have instead of metacarpals, we have the metatarsals, just like we did carpals, tarsals, okay? So numbered 1 through 5, starting with the big toe, ending with your pinky toe. And then we have the phalanges of the foot, and those are named the same way. We have, and in fact, we actually, just like we see with the hand, we have 2 on the big toe, just like we have 2 on the thumb. And then we have 3 for the digits 2 through 5, okay? And then we name them proximal, middle, and distal, just like we've seen before. Go back to that calcaneus, okay? Here we see a nice visualization of it right here, okay? So this is your heel. Your Achilles tendon or your calcaneus tendon is going to be connecting down on this surface right here. And then this is where your... What is that notification about? Go away. This is where your ankle joint is going to be, okay? Between your tibia, fibula, and your talus bone. Anything else we need to know? No, that's about it. Another perspective. This is from a lateral outside edge perspective. So again, we do have some unique bones that we need. Talus, think of as being your ankle. Calcaneus, think of as your heel. Navicular is just kind of this little bony ridge right here in the middle of your foot. Cuboid is the other uniquely named one on the lateral edge of your foot. And then we have it's not visualized, but we have the medial, intermediate, and lateral cuneiforms. And that is going to be it. Congratulations, we are done with this lecture. So again, quick summary in terms of review. Start out, make sure you know all of the bones themselves, be able to identify them. Then think about the features, and as I emphasized heavily in class and in this lecture, be able to use those features to be able to distinguish left from right. Awesome.